And I often thought about that in the context of applications in women's health, where the data you have access to is far from ideal. And so you'll see traces of that throughout this talk. But without further ado, I'll get started. So today I wanted to talk about all the data we cannot see and what that has to do with advancing equity in machine learning for healthcare. So as I'm sure we're all familiar with, consequential decisions we make in healthcare increasingly rely on the data we observe. But the data we observe can be difficult to trust. And I like to call this machine learning's version of the streetlight effect, where observable data draws out only a small slice of what we'd like to see. And this is because data sets are often a product of complex human interactions and opaque data collection practices. And as a result, these data sets are inherently shaped by decisions and phenomena that we can't see. These include things like social biases, historical practices, legal requirements, in addition to even things like storage constraints and, of course, privacy regulations. And these are just a few examples of many different factors that make translating the real world into data difficult. And so the primary motivation for my research is the fact that these hidden influences have consequences for machine learning models which are trained on those data sets. So often problems with the data we observe can translate to undesirable behavior in machine learning models. So I like to start with this light example. It's one of my favorite examples of errors in generative models. So this is a sample of watch images that I generated using DALL-E last week. And strangely, each of these watches shows the exact same time, 10:10 a.m. And it turns out that this behavior can be traced back to the training data for the model. DALL-E is trained on images scraped from the web. And if you Google images of watches, you can see that all stock images are set to the exact same time, 10:10 a.m., which is considered this most aesthetically pleasing time for a watch. So if we wanted our model to generate realistic watches, we might want to see watches that display all times of day, but instead the data describe a single time optimized for sales. So of course, when these types of data-related quirks arise in medical data, the consequences can be more serious. So consider variation in medical practice across geographies. So what I'm showing you is approaches to opioid prescription, strong, weak, or no opioids at all in different shading, after the same surgery in different locations: Augusta, Aberdeen, and Adelaide. Confusingly, they all start with an A, but 3 locations in Australia. So what the authors find is that prescription rates vary widely, even after accounting for differences in patient populations. So if you show up after a wrist surgery in Aberdeen, you're much more likely to get opioids compared to getting that same surgery in Augusta. And so we know that this variation in medical practice can be due to multiple reasons. Sometimes guidance changes, sometimes racial bias is at play, but the bottom line is that it contains behavior that we don't want models to replicate. And it also raises questions around which doctors we want our machine learning models to emulate and how you should be able to suss that out from the data you have access to. So the driving motivation here is that applications of machine learning in health have to contend with differences between the data we collect and the data we wish to observe. And in particular, I think there are 2 problems we need to solve. We need to characterize this difference fully, and we need to build models that account for those differences. So I often study this question through the relationship between observable data and the behavior of machine learning models. The first area of my work reasons about the consequences of flawed data on machine learning models. And the second area of my work goes the other direction and asks if we can use machine learning to characterize the ways that data is flawed and compensate for them. So how can we do better with the realities of the data that we have? So healthcare is rife with examples of differences between the data we collect and the data we wish to observe. This is because data is often not collected for the purpose of training machine learning models, but that is what we are ultimately doing with it. I would say one example of these misaligned incentives is that codes are often recorded for billing purposes, not necessarily for prediction. So for example, while we would ideally see patients go in for routine checkups, we know that patients often go long periods of time without seeing a doctor, which can produce data that's missing. We also know that there are differences in collection of patient history between Black and white patients in the US, which can lead to worse predictive performance among populations with less detailed patient history. When patients do visit the doctor, ideally we'd see that their illnesses are correctly diagnosed. But we know that misdiagnoses are common, especially for medical conditions that are understudied or conditions where the diagnosis criteria are not standardized. And machine learning models here risk replicating patterns of underdiagnosis. And finally, we might hope to collect data that represents all demographics, but we might instead see a sample of patients shaped by different levels of health access, leading to data sets that are limited in terms of representation and limited in terms of the absolute number of examples that we have in populations we might care about. So each of these differences manifests as different behaviors in machine learning models trained on this data, and each are distinct and require different solutions. So my work has touched on each of these issues. I've thought about this in the context of menstrual tracking data. I've looked at the role of measurement error, both in terms of the labels and features available across several health outcomes, including intimate partner violence, emergency department outcomes, and cardiovascular outcomes. And finally, I've considered the relationship between data set size and performance and proposed methods to mitigate these types of limitations. A separate area of my work focuses on developing models that are more robust to incoming data during test time and deployment, and develops methods based on test time augmentation to improve an existing model's accuracy or uncertainty estimates when you don't have access to the model's internals or the training data. Okay, so today I want to talk about 3 of these works, the 2 highlighted and 1 in progress perspective. So this is kind of a roadmap of what we'll be talking about. So to start, I want to take a closer look at the consequences of coarse demographic data, which is a cornerstone in analyses of health equity. And in particular, I want to talk about race. This work is joint with my co-first author, Raj Mava, who's a PhD student at Cornell Tech. Okay, so race variables play a large role in predictive modeling and machine learning, primarily in 2 ways. The first is as a feature to train models, where they're used, for example, to adjust clinical risk scores. And the second is in the way we evaluate models, for example, to determine whether or not a model works equally well across different demographic groups. And in each of these cases, the race variable, at least in the US, looks a little bit like this. There are 5 coarse categories and 1 bucket named other. And even within this race reporting scheme, there have been very nice studies about this. There are diverse interpretations of what race categories are used to train and evaluate models. You'll see Black versus white versus other. You'll see Black versus non-Black. You'll see all types of interpretations of these standard coarse race categories. I would recommend this piece of work for a detailed discussion of race as a feature to train models, since this is a hotly debated topic, for multiple good reasons. But in contrast to this area of work, our focus here is to study how race is used to evaluate machine learning models. And doing so is important because we want to know if a predictive algorithm performs poorly in a marginalized population, since this risks exacerbating health disparities. Before we get to the machine learning, I first want to talk about where these race categories came from, which starts with the US Census in 1790. And for example, like legally in the US, minimum race reporting standards in healthcare are tied to race reporting standards put forth by the census. So the decisions that the census makes has a huge impact on the types of data we see. And these categories are often designed to reflect current economic and social values. So race categories in their first instantiation reflected the economic interests of tracking slaves and free people. If you jump forward to 1870, the census introduced a race category for a small but growing population of Chinese immigrants. And each of these categories has gone in and out of fashion over the course of the census's history. It's a really interesting topic in case you're interested to learn more. And when we fast forward to today, we now use 6 broad race categories in a category named other. And even these categories are subject to debate. So just this year, Middle Eastern and North African were added, which I think is a huge win, and is something that was debated in 1997 and has now been accepted 20 years later. And in the UK, this takes a different form, much different from these categories, where the categories are white, Black Caribbean, Black African, Black other. I think there are a lot of interesting questions about how you transport race methodology across countries too. So coming back to machine learning, we often see reports that a machine learning model's performance in a particular coarse race group. So let's say we know that this classifier achieves 95% accuracy among Asian patients. If I'm trying to decide whether to use this for an Indian patient, it's hard to know whether or not I should trust this estimate of accuracy. We know that there are important differences between Indian people and Asian people more broadly, and it's not clear that these matter for our assessments of machine learning performance. So this is the question we set out to answer in this work. So in other words, do coarse race variables like Asian obscure disparities in algorithmic performance? that we would be able to see if we instead had widespread access to granular race data. To answer this, we make use of Mimic4, which describes over 400,000 emergency department visits. And a huge thanks to the dataset creators for releasing this data. And I'll also pause here to say that if you're at all interested in questions related to granularity of race data, that this is an incredible public resource for doing so. So across this data, approximately 20% of patients include, or 20% of visits include a self-identified reported race. I'll use the term coarse race group to refer to the broader racial grouping, for example, Asian or white, and I'll use the term granular race to refer to more specific racial groupings, for example, Indian or Chinese. So one thing I think is particularly interesting here is that rates of identifying with a more granular group vary by coarse race. So a majority of white and Black patients identify as only white or Black, whereas a majority of Asian and Hispanic patients do identify with a more granular subgroup. So even these dynamics vary across coarse race groups. So we designed our experimental setup to capture a broad range of settings in order to describe a set of risk scores, outcomes, and metrics that capture what researchers in machine learning for healthcare might care about. So we look at these 3 machine learning-based risk scores and 2 pre-existing clinical risk scores. And in terms of outcomes, we include 3. We have predicting hospitalization after an emergency department admission. We have predicting ICU admission or death. And we have predicting an ED revisit within 3 days. And then finally, we consider 4 separate metrics. And each of these metrics implies something different about model behavior. If we wanted the false negative rate to be similar across groups, this is equivalent to saying that we want a similar number of errors on positive examples across groups. So choosing the right metrics to capture the relevant notions of fairness, this is its own subject of research. And we chose these metrics to reflect the breadth of metrics that people might care about. And I think that the short headline from our results is that we find that coarse race data does indeed conceal significant disparities in clinical risk score performance. So here what I'm doing is I'm plotting the AUC for each coarse race group in a different color, and that's that shaded line across each of these groups, and the AUC for each granular race group with different dots. And each of these points shows the median performance and 95% confidence intervals for granular group AUCs across 1,000 runs. So the variation within each of these groups is striking, and it suggests that we're missing quite important sources of disparities in algorithmic performance. And we see this regardless of the outcome we look at too. So we replicate this in the context of predicting ICU admission or mortality. We replicate this when we predict ED revisit, again, variation in performance among the granular race groups within a coarse race group. And so you might ask, okay, what about these other metrics? We've only been talking about AUC so far. And so what we do here is we include a star if there is at least one granular group with significantly different performance compared to the coarse race group, where more stars correspond to lower p-values. And when you're doing this many comparisons, you're bound to uncover significant differences due to noise. So as a result, we adjust for multiple hypothesis testing here. And I think this table is quite striking because it suggests, regardless of the outcome or the metric or the coarse race group you choose, you're likely to be missing important disparities on the granular race level. The final analysis I want to share from this project is that we can ask how variation in performance within a coarse race group compares to variation in performance between coarse race groups. So we do this comparison to illustrate, okay, past research in health equity has focused on variation in performance between the coarse race groups. How does this compare to the variation we might be missing? And so each panel here corresponds to a different metric, and the blue points represent variation within the coarse race group averaged across groups. And the red point corresponds to variation in performance between the granular groups within a coarse race group. So we see that the blue point is often further right than the red point in 8 of the 12 comparisons here. So in these cases, this supports our hypothesis that the variation we should be focusing on should be granular race variation as opposed to coarse race group variation. So one thing you might say to this is that, okay, coarse race groups are larger than granular race groups by definition, so there will be lower variation. But what we do is we also control for group size when we do this analysis. So group size is kind of not a confounding factor in this analysis. Okay, so For additional results, I'd encourage you to look at the paper, but we also looked at why these differences arise, and we looked at differences in the distribution of data between granular race groups. And what we find is that there are significant differences in symptoms, differences in outcome rates, and differences in symptom outcome relationships between granular race groups. So I think there are opportunities for a lot of further research on how different diseases manifest across these granular race groups as well. Okay, so the section takeaways here are that based on our findings, it suggests to us that healthcare providers, hospital systems, and machine learning researchers should strive to collect, release, and use granular race data in place of coarse race data. And one thing I might add to that is that when releasing granular race data, I think we have a ways to go in terms of transparency around those data collection practices. There are differences between self-reported race, perceived race, collecting race via a form versus a phone call, and there is a lot of research on those topics. So I think that that's another place where better data would be useful. And then finally, our results suggest that existing analyses might significantly underestimate disparities in performance by relying on coarse race data. Okay, so I might pause here in case people have questions on this section. And I'll just check the chat. Thank you for sending the paper, Lizzie.
No worries. Yeah, people feel free to unmute or also write in the chat. Otherwise, we can also take questions at the end.
Yeah, that's perfect. Okay. And also feel free to interrupt if there's anything that you're confused about too. Okay, so what we talked about in the past section was a case where the available data was not ideal, and we characterized the impact, like what we basically described what we might be missing with access to suboptimal data. What I want to do is shift gears a bit to discuss what we can do about unreliable data. So what can we do to better estimate quantities given unreliable data? And specifically, how we can measure health disparities for underreported outcomes. Okay, so here, what we'd like to estimate is health disparities, but underreporting can lead to a distorted view of the prevalence of an outcome. So instead of observing the true number of positive cases across demographic groups, as pictured on the left, we might observe something closer to the right, lower numbers of positive cases across all groups. And when reporting rates differ between groups, this can lead us to think that an outcome is more common in one group compared to another when that's not the case, which is that the central quantity that we're looking at in health disparities research. So differential underreporting is bad news for health disparities estimation. And underreported outcomes are extremely common, both in and outside of healthcare. So the motivating conditions for this work were in women's health. For example, intimate partner violence and endometriosis. But even beyond women's health, crime is underreported, toxicity is underreported, and so on. But we'll keep intimate partner violence and medical conditions more broadly as the running example, since these are what motivated this work. So a natural question to ask here is, can we estimate the absolute prevalence of an underreported outcome? And sadly, the short answer is without additional assumptions, it's impossible to estimate the absolute prevalence when you have access to an underreported label. And plenty of people have proven that this is impossible without additional assumptions. And the assumptions that have been provided by prior work are unlikely to be true in healthcare. So let's walk through what that means. So let's say that 6 of 10 women in this group are experiencing intimate partner violence, or IPV, as I'll call it throughout this talk. Of the 6 positives on this slide, outlined in green, 3 are diagnosed as positive. So we have a reporting rate of 50%. The remaining patients are all unlabeled or undiagnosed and comprise of a mixture of undiagnosed positives, outlined in green, filled in with gray, and undiagnosed negatives. So what we observe is green people and gray people, diagnosed positives and the unlabeled. One assumption that's common in the literature is something called a positive subdomain. That is, there is a set of patients that we can identify as extremely likely to be positives. And if we're able to identify this group, and if reporting in this group is representative of the entire population, we can identify the reporting rate, in this case 50%, and extrapolate to the whole population. So coming back to intimate partner violence, this would mean that there is some symptom or combination of symptoms that identifies a positive case perfectly. And based on common sense and domain knowledge, we know that that's not true. Symptoms in IPV overlap a lot with other outcomes, so this isn't a worthwhile assumption to make. So we're in this place where existing methods can't help us with this particular outcome. So a natural question to ask next is to say, do we need to estimate the absolute prevalence in a given group? And maybe not. Sometimes, especially in health disparities research, we care about how much more common an outcome is in one group compared to another, or what I'll call the relative prevalence. These include statements like the fact that pregnancy complications are 3 times more common in Black women compared to white women, how adverse drug events are 3 times more likely among women compared to men. And these are useful statements. These specifically have been cited in support of policy that funds research to reduce these disparities. And it'd be useful if we were able to make these statements for underreported outcomes. Conveniently, the relative prevalence is also easier to estimate compared to the absolute prevalence. So say we have these two statistics, 45% of Black women experience IPV during their lifetimes compared to 35% of white women. We can then use the absolute prevalences to compute the relative prevalence to say Black women experience 28% higher rates of lifetime IPV compared to white women. But we can't go the other direction. So this suggests and illustrates that there are cases when you can estimate the relative prevalence, even when you can't estimate the absolute prevalence. One can be estimated from the other, but you can't go the other direction. So our goal is using this insight is to estimate this quantity for different subgroups. And what we do is we develop PURPLE, which stands for the Positive Unlabeled Relative Prevalence Estimator. And we estimate the relative prevalence between two groups, where these groups could be defined based on age, race, or insurance status. So let's set up some of the notation that we'll use in the later slides. We'll use Y to represent the true diagnosis for each patient, which represents whether they really experience intimate partner violence. We'll use S to refer to the observed diagnoses. That is, the person experiences intimate partner violence and receives a diagnosis for it. And then we'll refer, so for some subset of the patients who truly experience IPV, they will not receive a diagnosis. And for these patients, Y is equal to 1 and S is equal to 0. And finally, for a subset of the patients with no diagnosis, they truly don't experience IPV. And so for these patients, S is equal to 0 and Y is equal to 0. And this is standard notation in positive unlabeled learning. So what PURPLE does is it relies on 3 assumptions to estimate the relative prevalence. So in the first, what we do is we assume that all labeled examples are definitely true positives. So this is equivalent to saying that all patients with a diagnosis of IPV truly experience IPV. And with a diagnosis like IPV, we can be confident that this is true. It's unlikely that a doctor lists this in the HR if there isn't evidence of it. The second assumption is that the probability of diagnosis depends only on the true disease status and a patient's group. So this is a relaxation of a classic assumption in PU learning. Usually methods assume a fixed reporting rate across all groups, and we relax this to allow the reporting rate to depend on the group G. So note that this does allow the likelihood of IPV to vary with different symptoms, or to say that certain symptoms can more strongly indicate IPV compared to others. Despite this relaxation, I'll admit this is still a strong assumption, and we show in the paper that the method degrades gracefully under violations of the assumption. Our last assumption is the constant P of Y given X assumption across groups. So specifically what this says is that patients in different groups arriving with the same symptoms have the same probability of a positive outcome. So concretely, this means that an Asian patient and a Black patient arriving with the same injury have the same probability of IPV, and nothing in the literature suggests that these conditional probabilities should be different. So note that this still allows outcome frequencies to vary by group. Certain symptoms can appear more frequently in one group compared to another. This is just equivalent to saying that the groups only differ by differences in distributions of symptoms, not differences in conditional probabilities. So what these assumptions can give us is a probabilistic model of diagnosis. Basically, what we do in the paper is apply these assumptions to simplify this conditional probability on the left to equal what I've written out on the right. And you can refer to the paper for like the exact derivation. And what we do is we break the probability of diagnosis into two terms, the probability of a positive case and the group-specific labeling frequency. So importantly, we can't estimate P of y equals 1 given x perfectly from this expression because we're treating y as a latent variable here. We only have access to s, x, and g on the left, and we're breaking it up into these two terms. And what I mean by that is that there are multiple solutions for P of y given x that can appear to be similarly good. So in other words, we can multiply P of y given x by 2 and divide the second term by 2, and we would see the exact same number on the left. And it's hard to disentangle which of those factors is correct. So what we really get out of this expression is a constant factor approximation of P of y given x. So some multiple of the true value. Under the hood, how we implement this is we implement P of y given x as a neural network and the reporting rate as a group-specific parameter. And we learn all of these parameters using gradient descent on the cross-entropy loss on the observed data, which we have access to S, X, and G. So this is quite flexible to any parameterization for these two probability distributions. Okay, so just to summarize what we've discussed for this method, there are three inputs: the observed features X, the observed labels S, and the observed group G. And the method happens in two steps. We use this decomposition of the probability of diagnosis to estimate P of y equals 1 given x up to a multiplicative factor. And then in the second step, we use this approximation to estimate the relative prevalence. And we show that being off by a multiplicative factor isn't so bad because it cancels out in this fraction. So that's the high-level summary of the method. And finally, as we discussed, Purple relies on three assumptions, and we include experiments to demonstrate how Purple responds to violations of these assumptions in the paper. Okay, so I'll pause here too in case there are any questions. Thanks for the clarification, Lizzie. I know I switched between IPV and intimate partner violence.
All good. Yes, please.
Yeah, I have a question, or rather small clarification, because I think they've gotten confused. But
Sure.
so for this method to work, we assume that Py given x is constant. Oh, well, is the same between groups. So how does that play with the fact that we were then calculating ratios? Are we saying that, for example, if one group is 3 times more likely to be a victim of IPV than another group, is it solely because of the covariates?
Yeah, that's a good question. So could you restate the last part of this to make sure I understand?
Yeah. So if we think that Py given x is the same, and then at the end, what we want to find is a statement like group A is 3 times more likely to experience IPV than group B. Are we saying that that sort of difference is only carried by differences in covariates in the two groups?
Yeah, that's right.
Oh, I see. That's very interesting.
So I'll give you one example where that's not true, for example. So let's say I'm trying to look at senior citizen IPV compared to IPV for women in their 20s. The differences, the IPV between those two groups has been shown to manifest differently, that there are more emotional symptoms or like mental health related symptoms in senior citizen IPV compared to IPV in younger patient populations. In that case, the difference in rates of IPV is not just because of a difference in covariates. It's also because the conditional probability of IPV given the symptoms is also different. And so it is an assumption you have to be careful with in terms of choosing outcomes and groups for which it's true. Does that make sense?
Yeah, thank you so much.
Yeah, of course. Thank you for the question. Okay, so now we have we've gotten past the method. We've summarized high level what it does, and there's also code to implement this as well, in case you'd like to try this out with an underreported outcome that you are interested in. So one thing that's quite interesting in this work is that evaluation for underreported outcomes is quite challenging because you rarely have access to ground truth. And so how we evaluate purple is in 3 ways. We first use synthetic data, where we generate the observed features, true labels, and observed diagnoses. Second, we look at semi-synthetic data, where we generate true labels and observed diagnoses based on real observed features. And then finally, we move to real data, where we use real features and real observed diagnoses, but we have no access to true labels. So our validation of purple takes this three-prong approach. And so today I want to talk about our real data results, but of course we have the synthetic data and semi-synthetic data results in the paper. Okay, so the real health data that we use is something called the 2019 National Emergency Department Sample, and it describes over 15 million visits from adult women to emergency departments in the US. And the relative prevalence estimates here reflect the relative prevalence of IPV conditional on appearing in an emergency department. And the group data we have access to are things like income quartile and insurance status. And I would say the headline result from our paper is that purple produces relative prevalence estimates that are more plausible based on the prior literature than observed estimates. So here I'll walk you through what these plots say. So on the x-axis, I have different income quartiles. And on the y-axis, what I've plotted is the estimated relative prevalence. So the prevalence in that group divided by the prevalence of the remaining groups on the x-axis. So if the point is above the dotted line, it says IPV is more prevalent in this group compared to others. So using the observed diagnoses, the estimated relative prevalence follow this non-monotonic pattern. Using the purple adjusted relative prevalences, we see this monotonic pattern between income quartile and estimated relative prevalence. So you might ask, why should we believe the trend on the right over the trend on the left? And the answer is that an overwhelming amount of past literature supports a monotonic relationship between these two variables. And it suggests that the observed diagnoses are missing something important in terms of really helping us understand health disparities. So here, what I've plotted on the y-axis is relative prevalence of the outcome. Something that purple also gives you is relative prevalence of underreporting. So because you're estimating reporting rates in different groups, you also get a ratio of reporting rates between those groups. Okay, the final result I want to share is that purple also provides evidence that IPV is underreported at higher rates among Medicare recipients who come from lower socioeconomic statuses. So here you can see that in that the purple estimated relative prevalence is higher than the observed estimated relative prevalence. And so discrepancies between these two estimates suggest that one, underreporting may be affecting our estimates, and that purple might be a good option in this case. And then finally, we replicate our results on Mimic, and we find concordant results with respect to insurance, albeit with larger error bars since this is a dramatically smaller sample size. Okay, so the takeaways from this section are that we developed Purple, a method to quantify health disparities for underreported outcomes. What we did was apply Purple to a data set of over 15 million emergency department visits to produce the first estimates of IPV health disparities corrected for underreporting. And finally, we show that we can answer useful questions about underreported outcomes by switching our estimate of interest. So instead of targeting the absolute prevalence, we were able to make progress by targeting the relative prevalence. And that allowed us to make more reasonable assumptions. Okay, I'll pause here in case there are additional questions. Sweet, we can move onwards. Okay, so the final piece of work that I wanted to talk about, which is joint with Emma Pearson, Raj Mava, and John Kleinberg, is the idea of problem selection as a way of advancing equity in machine learning for healthcare. And in particular, I want to talk about the use of large language models to promote equity. So in recent months, there's been a lot of interest in the social impacts of large language models. Emma, Raj, and I spent some time last year hand annotating a random sample of these equity-related publications in machine learning. And what we found is that 85% of these publications focus on harms and only 15% focus on opportunities. So in other words, much of the discourse around how they'll impact social equity has been cautionary or negative. And while this work is extremely valuable in ensuring LLMs benefit the world, we felt that an optimistic viewpoint, that is, what new problems in equity can LLMs allow us to tackle, was underrepresented. So in response, we wrote a perspective piece on particularly promising applications of LLMs to promote equity. So we illustrated these 4 general use cases, and we grounded them in particular applications to promote health equity, starting with detecting human biases. So one thing that we found really exciting is that relative to prior methods, LLMs can more precisely characterize subtle linguistic biases. So for example, changes in sentiment or tone or stereotypes that rely on understanding the surrounding context within a clinical note, for example. And exciting work in this direction has already begun. And if you're interested, I'm happy to send you sites to these pieces of work with exciting results in using LLMs to identify, for example, biases in medical textbooks, quantifying patient compliance or perceptions of patient compliance from clinical notes, and stereotypes from clinical notes. So I think that this is an exciting area for more work to be done. Second, we're excited about the use of LLMs to create structured data sets for equity research. So equity research relies on these structured data sets, which track standardized sets of fields in a consistent way. For example, the race of a patient or the patient's health insurance provider. And this is really what allows us to quantify disparities and develop policies to mitigate them. And here, what I'm most excited about is the use of large language models to parse these fields from unstructured text, to expand the surface area of data sets that we can use to study these questions. One thing that I'm particularly excited about is the use of large language models to extract information from clinical trial reports to automatically quantify the diversity of those clinical trial reports and understand how diversity in patient populations might be improved in the future. Close this. A third line of work that is emerging is the use of LLMs to improve equity of access to information, to provide accurate and understandable answers to patient questions, where LLMs can be applied to translate clinical jargon, for example, diagnostic reports, clinical notes, treatment plans. And I think that there are even opportunities beyond this where LLMs can be used to explain what benefits Medicare patients are eligible for and help patients navigate the bureaucracy that's required to, receive sufficient care. And I think what we see, the role we see for LLMs in this pipeline is definitely not a replacement for clinicians, and not a magic bullet to displace existing efforts to improve access to care, but rather is a scalable supplement on top of these efforts that's low cost and can be used by everybody. And then finally, I think another area that I'm quite excited about is the use of LLMs in clinical trials. So in many domains, people have to navigate specialized matching systems to get access to resources, and often the design of these matching systems disfavors underserved populations. So in clinical trials, for example, there are these really complicated eligibility criteria, which can be both difficult to parse and inadvertently exclusionary towards patients of particular demographics. And the consequent lack of diversity among clinical trial participants reinforces health disparities and makes it challenging to understand treatment effects in these populations. I think there are a lot of exciting opportunities here, including applying LLMs to interpret inclusion and exclusion criteria and suggesting eligible patients based on those criteria, and finally relaxing those criteria and simulating what those relaxations might do to clinical trial cohort diversity. So our goal here in illustrating this breadth of possibilities is to show that advancing equity in machine learning for healthcare involves more than just playing defense against biases and failure modes, and involves also going on the offense to apply them positively to equity-enhancing use cases. So yeah, I would say that's kind of the major takeaway from this piece of work. Okay, so today we talked about 3 concrete ways to advance equity in machine learning for healthcare with respect to the earliest stages of the machine learning pipeline. But there are a lot of open questions as we grow closer and closer to a world in which machine learning models are widely deployed in high-stakes settings. Thank you for listening, and I'm happy to take any questions.
Thank you very much. That was a very eloquent and interesting talk. Yeah, lots of fascinating research you managed to squeeze in your PhD. I have a couple of questions, but if anybody wants to kind of jump in before me, please feel free to raise your hand or put a message in the chat, or also just unmute yourself and ask. I can kind of ask the first question whilst everybody else is thinking. I was interested in your first piece of work, you were talking about ethnicity or race categories. And I was wondering if there was also, so I work with UK electronic healthcare records, and as well, alongside of kind of the ethnicity categories, we also have a category which is often called missing or unknown. And I was wondering if something like that also exists with the data that you work with. Can you actually look at the people that don't have an identified race category?
Yeah, no, so that is like a huge category in this data set, and we decided to exclude them for exactly this reason. It wasn't clear why people end up with this field. And I've come up with a few reasons based on like talking to people who collect this data. Either the methodology wasn't adopted, so it's like an unknown because it wasn't asked. There's unknown because somebody doesn't want to report it and they're worried about disclosure of that piece of information. And then there's unknown because they don't identify with any of the existing categories. And so I think it's really challenging to identify what race those people are, even though it's a big set of people, often with the worst health outcomes. At least that's how it is in our data set, where they the unknowns have the worst health outcomes. So I think it is very difficult to disentangle that. I'm a little wary of the methods that try to classify them as one of the races based on the incoming features. More because of like a skepticism of like race classification as like a robust predictive setting. Like I think that the benefits of doing that may not outweigh the costs of predicting race for all the unknowns. Does that answer your question?
Yeah, no, it's really interesting. I think also sometimes in the data that I have is that because the data is drawn from different places, you can also have different ethnicities recorded depending on where the data has come from. And that's also quite interesting about, you know, what you choose.
One thing I think is cool that about data from the UK is that the UK for some reason is like way ahead of the US in terms of recording mixed race. We don't have any mixed race fields.
That's interesting.
But I don't know, it seemed like there were like different options for mixed races that are logged in certain forms, which I thought was kind of cool.
Yeah, for some groups, I think for sure.
For some groups, yeah, I don't think it's comprehensive.
Still limited. Kate has also put in the chat that in England it's reported that clinicians are too worried to ask the ethnic group. Sometimes they just guess. Which is definitely
I think that that's true even when race is used as a feature for different models. Like if they're trying to estimate the dose for something or estimate a patient's risk score, that's a case where I've heard that race is estimated most frequently, which has a big impact on your treatment.
Yeah, definitely. Does anybody have any questions they would like to bring forward? Don't be shy.
Also an issue with individuals having different ethnicities. Yeah. I think that what I have read from like the race data collection literature and like medical sociology is best practices are just to routinely collect race. At MGH, for example, they're required to ask patients for their race each year. I don't know how frequently that's done, but that's like the guidance. But yeah, I think that all of these problems suggest that we need to move beyond race at a certain point, but it's like the best thing we have for now. So yeah, I think that like all of this is like, these are all like band-aids on like the underlying issue, that it's not an excellent construct to be relying on for analyzing health disparities. But yeah, what I've seen is routine collection of race to address these differences over time.
Yeah, thank you. I think Vincent, you've got your hand up. Do you want to come in?
Hi, thank you for your presentation. It's absolutely amazing. I joined a bit late, so I may have missed this. I joined when you started talking about IPV and adjusting the predictions from, let's say, some are marked as negative to positive based on adjusting, let's say, based on characteristics.
Mhm.
This purely used for, let's say, comparative, not effectiveness, making, relative comparisons because my background is philosophy and theology,
Mhm.
and like machine learning is evil. Sorry, not evil, but
No, I get it.
yeah, I think the prediction bit. If we, let's say, predict someone as a false positive for this, it might be a reflection on their partner. Which, yeah,
Yeah, I think that yeah, I think it's a very valid concern. Within that project, I think the focus on the epidemiologist as a user and like aggregate results as like
yeah,
an outcome, saying like, oh, I'm interested in the true prevalence or the true relative prevalence, kind of sidesteps the issues of predicting whether or not somebody suffers from IPV. Um, yeah, I think it is a prediction problem that like is not so clear that it is a good thing
I
on
noticed
an
that.
individual level.
Yeah,
Yeah, I think that the reverse also happens where underreporting occurs because nobody wants that diagnosis, or like people don't want that diagnosis recorded
yeah.
um, and stored in infinity. So clinicians I've
So,
talked to have said that they get requests from patients to remove it from the record.
you've noticed, let's say, nursing staff in the UK just writing it on their glove or something, or
Mm,
doing something on their glove to notify other, but very rarely in the electronic health record. But
yeah,
I'm very worried about predictive stuff because of these stigma and
yeah.
positives.
No, I think it's a valid concern. But yeah, I always feel like there's a tension between like, oh, we do need good estimates of the prevalence of these things if we are to do something like at a systemic scale about them.
Yeah,
Um, but I do think there are open questions about like the privacy of those predictions, what they're ultimately used it for on an individual level.
yeah,
Um, so yeah, I think very
thank
valid
you.
concerns.
Absolutely great work. Thank you.
Thanks, Vincent.
Has anybody got any other questions? Yes, Jose?
Didn't mute. Okay. Thank you for the presentation. This was really interesting. All three sort of parts were sort of eye-opening. There's a bit of an aside, but do you think we have this same problem of granularity in deprivation and sort of, I know in the US, sort of separation between Medicaid, Medicare, and so on is very common to as a proxy for deprivation. And in the UK, we use sort of these scores that is just usually one number.
Mm-hmm.
Do you think, or have you thought, or do you want to look into sort of whether this granularity problem is also happening in how we measure deprivation?
Yeah, that's a good question. I think that I'm sure it happens with other measures too. Um, I think race is particularly egregious because we know there's so much heterogeneity within these coarse race groups. Um, I could see the same thing happen on a geographic level too, like when you're doing analyses on a state level in the US. Different areas in the same state are very different. I don't know if I would expect like socioeconomic status, like a continuous variable like that, to have the same issues. But I do think it's a good question. I think race to us felt like one of the more important ones because it's used so widely in algorithmic fairness analyses and health disparities analyses that it's useful information to know if it's misleading.
Okay, thank you.
Yeah. Oh, the other thing I'll say is like, I think that there is more debate about like the benefits versus the costs of collecting granular race data. In that, like, in the census in 1997, they were like, oh, like we'd love to collect granular race data, but it'll be too difficult or it'll be too confusing to log. Like the cost to the person filling out the form, it's too high. So I think that's another motivation why we felt like race in particular, compared to some of these other variables, like was an important discussion to contribute to. Because I think there is resistance to recording and releasing granular race data.
I'm going to sweep in with maybe a slightly difficult question, and just to finish up, because there is kind of a very big ongoing discussion about what data are we missing, and kind of, you know, websites that capture data sets that should exist but don't. Do you have a data set that you wish existed but doesn't currently?
Yeah, it's a great question. I feel like my answer somewhat changes, but today my answer is I think that a big piece of missing data for women is their like data on their menstrual cycles, and it's rarely integrated with their longitudinal patient history or like their health record. So you have like a lot of research that focuses on menstrual tracking data. You have a lot of research that focuses on EHRs, but the integration of those two things is quite minimal, even though they should be complementary to one another. And it's an important piece of missing information for like a lot of people. So I think one data set I'd love to see is one in which you have menstrual tracking data linked to somebody's electronic health record recent like history, which I think could improve our ability to track and treat diseases in women's health.
Definitely.
Yeah,
thank you
that's
so
my current
much.
answer.
Yeah.
Sorry.
Yeah, very vital. I would also love to see that. Thanks. Yeah, thank you so much for such an interesting talk, and being a wonderful speaker. It's been really fascinating. I popped some links in the chat, so some papers of Divya's, and also links to the Data Science for Health Equity website and the YouTube channel where you can find a recording of this once it goes online. But yeah, thank you so much for everyone's time. And do get in touch if anybody has any questions. And the next statistical methods webinar will be in July.
Thanks all for being so
engaged. Good. And lots of thank yous in the chat. But thanks so much.
Great.
And have a good day.
Bye. See you
Cheers,
later.
everyone. Bye.
Bye.